Hello, everybody. Welcome to the Neurotransmitters, a podcast about everything related to clinical neurology with the goal of reducing your neurophobia. I'm joined today by Dr. Bilal Butt from the University of Maryland, and he's going to be helping us out with some neurocritical care issues today. Thank you so much for joining us.
Oh, thank you. Thank you for having me. I really appreciate it, and it'd be a pleasure to be here.
When we were talking online earlier, you mentioned talking a little bit about aneurysmal subarachnoid hemorrhages. So, when should we initially be concerned about more broadly, like an intracranial hemorrhage?
Absolutely. It's a very good question. And I think the first thing when we think of aneurysm or aneurysmal subarachnoid hemorrhage is this buzzword thunderclap headache or the worst headache of your life.
Mm-hmm.
And we've all read it in our review books,
Right.
and we all see it too in practice. In fact, I just saw one recently, and they literally tell you it's the worst headache of their life. And by definition, a thunderclap headache is a headache that comes on very quickly, matter of seconds, a minute, and reaches its peak very quickly. And the differentials for that are somewhat limited, and the top differential being aneurysmal subarachnoid hemorrhage.
Gotcha. When we say, obviously, these folks, they often tend to present to the emergency department pretty urgently. Now, let's say they get that headache, you get the CAT scan, and it shows no blood. What are your next steps as far as that goes? I know the sensitivity of a CT is pretty high, but it's not 100%. So, what guides your clinical decision making at that point with a negative CT head?
Very, very good thought. And if the differential of aneurysmal subarachnoid hemorrhage is there and your CT is negative and your suspicion is still high, I think as neurologists we are trained to find any blood in the brain that's not visible on the CT, and the way we do that is grabbing some spinal fluid and
Right.
looking for xanthochromia. And we have to be very careful because a lot of times these patients are in the ER, and we have to make sure that the lumbar puncture, as best as possible, is non-traumatic, so we can find this hidden aneurysm, if you will, hemorrhage, and through xanthochromia, spinning the blood and seeing if we can find any evidence that there is some hemorrhage. And obviously, if there's a suspicion, we also look for imaging in the form of a CTA or an four-vessel angiogram, and see if we can find aneurysm there. But to answer your question, I think a lumbar puncture is key in this. And I've seen this in my practice where CT has been negative, and you ideally want to wait 6 hours or so before or after the onset of the headache to look for xanthochromia, as they can sometimes take time to show up in the
Right.
CSF.
Right. The evolution of the blood product degradation, that sort of thing.
Absolutely.
Now, now this is I'm going to throw a little wrinkle in there. Now, let's say we've got our CT that doesn't show any blood. We got a story that sounds like a thunderclap headache, maybe subarachnoid, and then we've got a CTA with like a say 5-6 millimeter aneurysm. Would you still pursue the CSF testing at that point in time? I mean, with the story otherwise hanging together quite well. Because I know sometimes that can be a hard sell to some people. Because even if there is no blood, some people might still consider that the quote unquote sentinel headache, and treat the aneurysm regardless. So I'm just curious, how would that change in your practice?
And that's a very good question, and a good dilemma. Now,
I know there's
like you
no
said,
right
it could,
answer.
yeah, yeah. I mean, it could be a sentinel headache, and not necessarily a sentinel headache doesn't necessarily mean the aneurysm ruptured. It could just be that the aneurysm is this expanding in size or morphology, and that necessarily would not show up as blood in the CSF. And if you have no other suspicion or other diagnosis, um, and you're left with that aneurysm hanging in there with no other explanation for the headache, especially a thunderclap headache, I think more than not it would end up being treated.
Gotcha. No, I think that makes sense. I can't think of too many people who would be so conservative as to just say, oh, let's just watch it for a little while, right?
Oh, absolutely,
Um,
absolutely.
but let's go back into the more traditional course. So let's say we've got a little bit of a subarachnoid blood on the CT. What tends to happen next with the patients? Where do we go from there with their management?
Well, I mean, for one, this is one of the more common etiologies in neurology that, as far as subarachnoid, we see in the neuro ICU. And so they all end up in a neuro ICU somewhere, hopefully. But the immediate treatment for these patients happens in the ER, and it involves around controlling their blood pressure, which can increase the risk of re-rupture, and reversing any blood thinners if there are any blood thinners. The traditional obviously start with ABCs, and the idea is to see if we can find that aneurysm and get it treated as quickly as possible. Now there are ways to around it if you're not in a main center or if you don't have access to somebody who can treat the aneurysm. There are ways as far as giving them medications such as Amicar or TXA and kind of thickening the blood, if you will, and getting them to the nearest endovascular center. And some people argue with giving seizure medicines for seizure prophylaxis. That's a little bit of a controversy. And sometimes they need to be assessed for extraventricular drain as well, based on the neurological examination and their CAT scan. And so that's the immediate treatment. And there are other treatments as well that tend to be a little more after the ER visit.
So let's say we have someone who's, markedly hypertension, systolic in the 180s to 200s. What's your preferred medication for kind of bringing that down in a relatively urgent fashion?
I think most places use anything between nicardipine, Levoprex, calcium channel blockers, essentially, or even labetalol is used. But usually they end up on a drip if the blood pressure is really high, and if there's a component of pain, as far as the blood pressure being high because of pain, then treating the pain obviously is very important as well. But usually, I think nicardipine, to answer your question, is probably the most preferred agent.
And I know, at least when I've spoken to ER docs in the past, part of their concern is that it's not as immediately available because, you got to mix it in the pharmacy. The bag has to be prepped. And so I know a lot of ER docs are reaching for labetalol initially. And I know that that's, obviously we're a little more biased because we're taking care of folks once they get onto the inpatient side. But the studies do tend to show that the blood pressure variability tends to be associated with potential worsening outcomes, as opposed to a more, even if it is mildly more elevated, with a more stable blood pressure. Has that kind of mirrored your own personal experience as well?
Yeah, I mean, I would say I would agree with you, and it can be hard sometimes, really, in the acute phase, controlling that blood pressure as well. But I agree. I mean, blood pressure variability can be a predictor in outcomes, like you mentioned.
And I know, well, I shouldn't say I know. I've been anecdotally told that hydralazine is a little less favored in most neurocritical care cases. Is that correct? Like just due to like ICPs and things like that?
Yeah, I mean, I'll put it this way. In one center I worked at, hydralazine was a big no, and the other center I worked at, hydralazine was okay. I don't know if there's a general consensus, to be honest, is if we should avoid it altogether. But I agree with you. Like where I'm at, where had been, hydralazine was something that was not the first line, if you will, and tended to be avoided.
Gotcha. And I think it is probably more consistent to say that nitro drips are generally very much frowned upon with intracranial pathology.
I have yet to see one on board. Let me put it that
Yeah,
way. Yeah.
right. Yeah, I know. The ICP, the intracranial pressure issues are always a concern, more immediately to the forefront of, I think, most neurocritical care thinking. But so let's say we've got someone who's coming in, they've been stabilized, they're getting admitted to the neuro ICU, they're undergoing all of their, catheter-based angiography, all that, looking for the aneurysm. Let's say an aneurysm's found, they secure it. How long do these patients need to stay in the ICU? I mean, obviously, it depends a little bit on how severe their case is, but what would kind of be your guiding philosophy as far as who stays in the ICU, who can be downgraded to maybe like, an intermediate floor, things like that?
It's a good question, and families ask this all the time. And unfortunately, if it is an aneurysmal hemorrhage, they buy themselves usually 14 days in the ICU. Um, and regardless of how good they're looking, usually they end up staying for a good 14 days. And the reason for that is you sometimes, can get complications. A lot of complications happens with these patients in the ICU. And the biggest one we're concerned about is a delayed cerebral ischemia or symptomatic vasospasm. And it can happen up to 14 days or even beyond. I've been up to 21 days, but usually we like to watch them for 14 days. Now, there is an entity called perimesencephalic um, hemorrhage, which kind of sometimes looks similar to an aneurysmal subarachnoid hemorrhage, with the exception we don't find an aneurysm. In those cases, personally, I would have them out of the ICU if everything's looking good and our suspicion is for perimesencephalic. I would have them out in a week or so. But a true aneurysmal subarachnoid hemorrhage, unfortunately, I mean, and it's, quite a bit of a challenge with the families when they see their loved ones doing so well, still in ICU for 14 days. But that somewhat has become a protocol, uh, unfortunately. But the ones that are not doing so well, families can understand why they're in the ICU.
Yeah. Now, you mentioned, and this is a great point. I was hoping you would bring this up, right? Delayed cerebral ischemia, or DCI. I would almost say formerly known as vasospasm. Um, for those who might not be familiar, how would you define that from a clinical perspective?
So, from a clinical perspective, it basically is a drop in your GCS of 2 points or more, a change in your NIH scale exam, um, or focal neurological deficit, if you will. It usually lasts for about an hour or so in the setting of this aneurysmal subarachnoid hemorrhage. And so clinically, that's the definition, is when we have a change in or a decline in neurological examination, and we attribute this to what you like you mentioned, DCI, and then if that is our suspicion, and then we go ahead and treat DCI. And unfortunately, uh, we have, or fortunately, I would say rather, we have some good treatments, and there's more on the horizon. And but if DCI is your suspicion, usually they end up. In the past, we used to do what's called Triple H therapy: hypertension,
Yeah.
hypervolemia, hemodilution.
Right.
That's kind of fallen out of favor.
Uh-huh. I know. I
And
keep seeing it referenced in critical care papers as like formerly. Yeah.
yeah, I mean, I trained in it. I trained in it, so it wasn't too long ago, and but now it's mostly hypertension, drive the blood pressures up, and get them to a catheter angiogram and see if we can inject calcium channel blockers or milrinone, verapamil, things like that to help open up those vessels. And we also use nimodipine, which helps with delayed cerebral ischemia as well and outcomes.
And I've seen in even severe cases, they might even do like partial balloon angioplasty on some vessels. Has that been something you see? I know that's very center dependent.
Yeah, honestly, I've personally not seen it, but can it happen? Absolutely. I think the preferred method initially is to try to inject drugs, if you will, to open up those vessels. And these is again, it's a temporary fix. Sometimes you need to go back multiple times
Right.
to keep injecting these drugs. Um, and our goal is to prevent the worst thing a DCI can do is cause strokes and worse outcomes. And I've seen that happen too, unfortunately, where they go back and regardless, they end up having strokes.
Yeah, it's really terrible because otherwise a lot of people with subarachnoids do recover quite amazingly.
I've seen cases where, believe it or not, patients come in and gift of hope was called, and the next thing you know, they're walking out of the ICU. I've seen cases where they looked very, very sick and didn't expect anybody to be walking in the clinic and talking to you. And so, yeah, I mean, in the acute phase, like I tell patients, it's if they're really sick, it's not about recovery; it's about getting them through this critical first 2 weeks, and then the recovery phase happens. And but yeah, absolutely, I mean, for how bad they look, and then initially they can look really good. The ones that make it.
Right. Yeah, I know. I still, just a little anecdote. When I was a resident, we did about 5, 6 months of neuro ICU, and there was this, sweet little old lady. She was in the ICU for just about my entire rotation that month, and I think it was a couple of years later. I wasn't even at the program any longer, but I got a card in the mail, and it was her standing up, like waving at the camera. And she sent, I don't know how she got my cell phone number, but she texted me like the next year on the anniversary of like, hey, I'm doing great. I'm out driving around in the community. Thanks so much, blah, blah, blah. And it really does, make everything that all this work that you're doing really worthwhile. To
Absolutely.
know that, yes, those people out there, some of them do make it through. They get back to a normal life. If you
Absolutely.
can get them through that initial really high acuity period. And no, it's always great to hear stories like that.
Absolutely.
Um,
Absolutely.
no, so to that point, who are these patients? Obviously, there are some different scoring systems that we use on admission to help kind of risk stratify these patients. So, who are the highest risk patients for things like DCI? What kind of things do we do to prevent it, and so forth?
So as far as DCI um, is concerned, well, before I go to DCI, but the scoring systems we have usually we use what we call is the Hunt and Hess. We have the Fisher, a modified Fisher scale, and then we also have the World Neurological Federation Society score, and all of these scores essentially tell you. One of them tells you about higher the score, the higher the mortality. The one of them tells you if the higher the score, the more likely you'll tend to have vasospasm. Um, Now, essentially tells you the worse they come looking into you, the higher likelihood they'll have mortality. The worse the scan looks as far as hemorrhage in the ventricles, thick blood, more likely they're going to have vasospasm. And what we can do to treat this or prevent this is one is basic things. Preventing fevers is one thing, is what we do in the ICU. Preventing fevers helps with preventing DCI. Keeping their blood pressures auto-regulated, so we don't, once the aneurysm is secured, we don't tend to be aggressively lowering the blood pressures, allow that perfusion. Other things we do is, nimodipine is something that everybody gets, has been studied in a British trial, multicentral, a British nimodipine aneurysm trial, which showed that nimodipine actually, now, although it didn't reduce vasospasm, but helped in better outcomes. And we presume the better outcomes was because it helped treat DCI in other ways other than vasospasm. And then looking at the sodium, for instance, a lot of these patients have hyponatremia, which can also be a risk factor for DCI. So we make sure the sodium is adequate, and we look for causes for hyponatremia, which the more common one, SIDH or cerebral salt wasting, and treat it accordingly. So it's just some of the ways we prevent DCI, and the way we treat it is what we discussed earlier. But if we can prevent it, that would be ideal.
Right. And I know there's a couple, some people talk about like transcranial Doppler trends, or in some of the really big, like quaternary centers, we also have like continuous EEG looking at like alpha delta ratios and things like that.
Yeah,
Which one do you tend to use more? What tends to be more available / reliable in your experience?
yeah. So I think the more data we have, the better. And at Maryland, we use both. So the patients that we think are high risk for DCI, they all end up getting transcranial Dopplers. And the transcranial Doppler is usually the middle cerebral artery is the most reliable numbers we get. And a trend is very important, like you said. And we look at the alpha delta ratio, looking how high or low it is, and can predict DCI even 3 days or more prior to even happening. So all these patients have EEGs. We look at their delta ratio. We look at TCDs, look at their velocities, and make a judgment based on that. But again, like you said, there are multiple ways to do it, and even TCDs with normal velocity doesn't necessarily mean that DCI is not happening. So which is why I wouldn't rely just on one test to make the call. It's clinical judgment with all the information put together.
So yeah, I mean, because there's certainly plenty of places in the country where they may not have like transcranial Dopplers or continuous EEG. It becomes one of those things. So if all you have is your clinical exam, let's say in a non-neuro ICU, should those patients what can those patients be treated optimally when all you have is your clinical exam to rely on? I guess that would be the question I would put to you.
Well, it optimally, ideally, you would want as much information as possible.
Of
And even a
course.
CT perfusion is something we use to look for delayed cerebral ischemia. And the counter argument could be that you do all these tests and they're normal, but your suspicion is high for delayed cerebral ischemia because of the exam. Then I agree with you that regardless of all these tests are telling you when your suspicion is high because of the exam, then they should be treated. And that's how we treat them. And I've done them based just on the exam and regardless of everything else being normal. And I think, to your point, clinical exam and your clinical judgment and suspicion precedes all these other tests if they're negative. So can you do it based solely on exam? Absolutely.
Yeah. Yeah, it's nice when everything lines up and your data is all concordant. But yeah, sometimes you're still like, it just doesn't look right. It doesn't feel
Exactly.
right. You get that clinical intuition that
Right.
just rattles around in the back of your mind.
Exactly.
So one thing you mentioned earlier, and I'm familiar with a little bit of this controversy in terms of prophylactic anti-seizure medication. In your own clinical practice, how do you tend to approach that? In say someone who has not had a seizure and is still under, is kind of in that little gap of maybe 12 to 24 hours where they haven't yet undergone like a catheter angiogram.
So yeah, I think, like you said, it's a little bit of variable, and I think if you ask a few different neurologists, will give you different answers, and I'm not sure what your preference is, but the way I personally do it is until the aneurysm's secured, they're on prophylactic seizure medications, and usually end up staying on it for about 7 days before it's stopped. Now, obviously, it's different if they've had seizures, but I tend to have them on uh, anti-seizure medications at least for the first 7 days um, while the aneurysm secured, and after that, it's stopped unless there's a reason not to stop it.
And yeah, I would tend to do that same thing in my own practice as well. Now, I know the tricky bit is always if they haven't had a seizure and no aneurysm is found on imaging, how do you still I would still tend to, at least in my practice, do you usually kind of treat like almost like an acute symptomatic type event and do the 7 days like you would almost for like a neurosurgical type patient?
I agree with you. And
Yeah.
if you don't find aneurysm and you think it's maybe paramesencephalic, and in 7 days they get repeat imaging and it's negative, then yeah, I stop it. And and there's a lot of controversy even with just intraparenchymal hemorrhage and seizure medications and in this newer trials. So I think it's a gray zone right now, but I'm sure other people have other thoughts. But personally, I don't keep it unless they've had seizures.
I tend to lean the same way. I know I've definitely come across neurosurgeons who do put it on for intraparenchymal hemorrhages, and I'm kind of like, okay, kind of shrug my shoulders. I'm like, oh, it's fine, I suppose. A week isn't gonna probably make a big difference, but I probably wouldn't do it. But I tend to be a little bit of a purist as far as that aspect of things goes.
Exactly. No, I'm with you on that. And I mean, it'd be a lot of patients ending up in your clinic with the seizure medications that never had seizures, and now they question you as to how long they need it and how to get off of it, when to get off of it.
Well, I
Uh,
mean, to be fair, that already happens.
well, you don't want
um,
that.
no, no. But I mean, it's good to work those folks up to get the right diagnosis eventually.
Absolutely.
Now you brought up another great point. These perimesencephalic subarachnoid hemorrhages. For those who aren't familiar, kind of where are they? Why do they happen? And how does that change our management when we see that pattern of blood versus different patterns?
So a perimencephalic, by definition, is usually around your midbrain. a little bit around
Mm-hmm.
your ambient cisterns, which is the CSF space around the midbrain. Usually not in the interhemispheric fissures, although can
Mm-hmm.
be a little bit of there. Um, Rarely causes hydrocephalus, although can cause hydrocephalus as well. Um, and etiology for that is deemed to be unclear, but thought to be from either some venous hemorrhage or some small arterial perforator. Um, and the workup essentially is the same as an aneurysmal subarachnoid hemorrhage, although we find no aneurysm. And the treatment um, also mirrors the treatment of aneurysmal subarachnoid hemorrhage, although the risk of hydrocephalus, delayed cerebral ischemia, is much less, and their outcomes are much better as well. And most of them can, have good outcomes, and for the most part, the hemorrhage doesn't reoccur. And Yeah, but for the most part, the workup is the same, and we also look for sometimes a spinal AVM that might have caused a hemorrhage, and we're not finding an aneurysm, and we look for other etiologies, a micro AVM in the brainstem, spinal AVM, and a lot of other reasons for aneurysmal subarachnoid hemorrhage. We got to make sure there's no mycotic aneurysm, which are small distal aneurysms from infection, um, arterial dissections. But usually these are all ruled out, and for the most part, we end up finding nothing. And believe it or not, these patients look good coming in. They look great leaving, and they usually have no issues.
That's good. And now you mentioned another, fortunately, somewhat common complication with subarachnoid hemorrhages, hydrocephalus. At what point does that warrant? I know, obviously we kind of monitor, again, clinical exam, looking for like serial scans, things like that for evolution. What kind of things should people be watching out for if someone's starting to show some sort of clinical or radiologic decline that was like, I need to get the neurosurgeon on the phone?
Yeah, so it's very center dependent. Some are very aggressive with the drains. Some are wait for clinical decline. And I'm personally of the opinion that if you have a clinical suspicion, radiographically it fits, then absolutely these people need drains, because without drains, they can decline very quickly and even end up dying with the elevated intracranial pressures. And the biggest thing we look for is obviously if there's nausea, vomiting, if there's a decline in a neurological examination, when they're more sleepy, could be more agitated even. And if the images fit where you see hydrocephalus, um, and there's blood in the fourth ventricle, you have a high suspicion the hydrocephalus is going to worsen, then a drain is very appropriate. And it becomes a little more tricky if the drain is put in before the aneurysm is secured. But after the aneurysm is secured and there's suspicion, these patients all, I think, should get a drain, because, without a drain, and if they worsen and that's missed, they can end up dying. But obviously the drain also has its complications. You can have to kind of weigh the both. But I'm the personal opinion that clinically should be followed, fit with imaging, and if there is a suspicion, a drain absolutely is necessary. And I think for the most part in large academic centers, they all end up getting drains if needed, and if they don't need it, they're watched closely in ICU.
Mm-hmm. And what I was always taught as a resident was that when you have very, very early hydrocephalus, the first place to look was like the inferior horns of the lateral ventricles, kind of in the temporal lobes there. Is that been your
Absolutely.
experience as well with
Absolutely.
subarachnoids?
Yep. We look at the temporal horns. That's the first place, like you mentioned, to looking for early hydrocephalus, and it can progress and involve more than just the temporal horns. But I agree, absolutely. Like you said, that's the one place we look for initially for hydrocephalus, and it becomes a little tricky if they have ex vacuo dilatation, and but absolutely 100% true.
So as people get towards the end of their 14, so let's assume that things have been going well, they didn't need a drain, the aneurysm's secured, the blood is slowly resolving on repeat scans. Where are patients usually heading, or is it, I assume, going to be very dependent on their level of function, kind of near the end of that 2 week mark?
Yep. So, I mean, it's a mixed bag, and in 2 weeks, if they're looking good, I've had cases where they end up on the floor, general neurology floor, and they go home. There's also cases where they go to rehab because of some focal deficits such as weakness and requires a little bit of rehab. There's also cases where unfortunately they weren't able to be extubated and they had a tracheostomy put in, and they end up also in rehab, and that can support a tracheostomy, a plus minus feeding tube. And there's also cases where you do the best you can, and neurologically they worsen, they become close to brain death, and then you have to have a family discussion about goals of care. Um, but like you said, it depends on their functional status. But our goal is to get them to the floor and eventually rehab, and then follow them up in clinic to see how they're doing, because a lot of these patients have memory issues, neurocognitive issues, and so still need to be followed up.
Absolutely. About what, again, in your estimation, in terms of mortality at time of discharge from the ICU, what numbers are we usually looking at?
So I mean, it's I guess you could say maybe the one third, you know, mortality. And well, I mean, a lot of times the patients don't even make it to us, you know, we're essentially excluding those cases as well. Uh, so it is, you know, it is a entity of high mortality, if you will. But now that if we can get to them quickly and treat them, there's a lot of ways we can change that, and a lot more ways that we're finding out that we can help these particular set of disease.
Yeah, no, I think that's absolutely right. If we are able to get them over that hyperacute period, there's a good chance that these people could have a really good outcome neurologically.
Absolutely.
So, kind of going back a little bit, there's a few things that can present similar to subarachnoid hemorrhages that might sometimes muddy the waters a little bit. One entity, let's say if we changed our vignette a little bit, so let's say that, someone has had repeated worst headaches of their life, sometimes associated with like sexual activity, things like that. For all neurology residents out there listening, that's going to like immediately trigger the board question for like reversible cerebral vasoconstriction syndrome, or RCVS. Does that differ in your workup at all? Like if say you have someone who has these episodes, or do you pretty much run them through a very similar diagnostic algorithm?
Yeah, so I mean, like you said, RCVS is part of the differential. The most common cause of subarachnoid hemorrhage is trauma, and so we, treat those differently. Although they can have complications of symptomatic vasospasm, but they're treated a little bit differently. But as far as RCVS, it's. I mean, one, it's not that common. We read a lot about it, but I can only say I've only seen a handful of cases. But yeah, it is treated differently. It's not treated as aggressively as we do the aneurysmal subarachnoid hemorrhage. I mean, it is treated with a calcium channel blocker. It's treated with a repeat angiogram in a few weeks, just to make sure that vasospasm has resolved. If it's truly RCVS, it should resolve. Around 12 weeks or so, we should have resolution. And if you think it's RCVS, a lot of times it's based on what do you think the etiology is. A lot of times they're on SSRIs, and we try to avoid whatever we think the trigger is for the RCVS. I mean, because there's really no aneurysm to treat. It's basically treating the cause if there is one, and the calcium channel blocker with whatever effect that has, and just hoping that the vasospasm resolves and their headache resolves, and it's kind of does the trick. But yeah, it's not so much of an aggressive workup that we do with aneurysmal subarachnoid.
Gotcha. As you said, right? We've been focusing mostly on aneurysmal subarachnoid hemorrhage. So, in terms of intracranial aneurysms, who are the people who are considered to be at risk? Let's say someone is worried, maybe I've got an aneurysm or I've got headaches. We don't want all of them coming in for CTAs of their head. But who are the people who should have perhaps a little more concern and maybe get that checked out by their physician?
Yeah, it's a good question because I'm sure neurologists in the clinic see headaches all the time. And when would you be worried about aneurysm? It's a hard question to answer because until you check for it, you won't know. But some of the risk factors are blood pressure, hypertension, smoking, symptomatic drug use, cocaine, amphetamines, and the Japanese Finnish population is at a higher risk for aneurysms. But aneurysms, I mean, it's been reported as high as, I mean, 2 to 5% in the population, and usually around the 2% mark. So 2% of people, sometimes people die not even knowing they had aneurysms on autopsies. And I think a big thing is if you've have family history of aneurysm is also very important to take in mind, if you, especially if you have two first degree relatives. And I mean, if they've had aneurysmal rupture in the past and they're coming in again, I would again kind of the would raise a suspicion. But yeah, it's a good question, and it can be a little complicated to know or rule out unless they've been checked for it. Uh, it becomes a little complicated, but I agree with you. It's just impossible to go start scanning everybody for aneurysms because it's just unrealistic. But nowadays we have treatment for aneurysms prior to rupture, and so a lot of patients are developing or finding out they have aneurysms incidentally, for instance, and those are getting treated and followed up on, and the rupture. For those patients, hopefully the risk is minimized because now they're getting treated one, because it's that incidental, or two, because we're just doing more of these imaging and finding out more and more people with these aneurysms. Or uh, other thing I should have mentioned is obviously polycystic kidney disease and some genetic conditions like Ehlers-Danlos and things like that should all play a role in looking for aneurysms.
Now, I know you're not an interventionalist per se, but I'm going to guess that in your practice you see more than a few aneurysms that are unruptured. At what point do you think it, like, if you're say a neurologist or even a primary care physician who has a patient, you have an incidental aneurysm, at what point do they really need to be seeing an interventionalist to talk about maybe like having coiling or some other type of procedure done?
Yes, I think if you have an aneurysm that's incidental, a lot of it depends on the location, anterior circulation versus posterior circulation, and the size and the morphology. Is it irregular? Does it have daughter sacs? So I think the best thing to do for these patients is to have them seen by endovascular neurologist who, even if the aneurysm is not being treated, they're followed up with repeat imaging. And the thing as a neurologist we could do for these patients is to limit the modifiable risk factors, smoking, drugs, hypertension. The rest of it is the natural progression of the aneurysm. And if it qualifies for treatment, they end up getting treated. If not, they're usually followed for increase in size or change in morphology. And if they have one aneurysm, there's almost about a 20% chance they have another aneurysm. So making sure we've located all the aneurysms and essentially kind of following it up, follow up. And then these aneurysms, just to be clear, they happen normally at branch points, which is very different from mycotic aneurysms, which are in distal arteries, just to make sure we have the right kind of aneurysm, which is a sacral or a berry aneurysm, which can be different from other types of aneurysms.
Yeah, yeah, and I know especially in like the ICU, as someone who might be like bacteremic or septic from some other organism, or maybe has a history of IV drug abuse, those mycotic aneurysms. In my experience, I've seen some pretty nasty clinical scenarios develop, and I'm sure you have as well.
Absolutely, absolutely.
I know every endovascular person that I've talked to about those in the past say like coiling. I'm just always, well, I shouldn't say always, but for the majority of times does not work well and tends to cause more problems.
Yeah, I agree with you. I mean, I think we don't have enough data to say what the right course is. I think the biggest thing is to treat the infection, which is the cause of these aneurysms. And hopefully, once that inflammation resolves, these aneurysms are very small, usually, and they kind of resolve. And these are false aneurysms, so they usually hopefully resolve, and you can follow up with repeat imaging. But yeah, there's no real good answer because although I agree with you, most of them don't get coiled. There's really not. We don't. I don't really know. what the best approach to these is. And I personally have not had any of them that were coiled, and most of them were just followed with antibiotics.
I know, and it's always challenging because especially if they do have a little subarachnoid blood, your hands just like start itching. It's like I should be doing something,
You're right,
which I
right.
know as a doctor is always one of those traps to fall into. Sometimes
Yes,
just gotta not do something.
exactly. I agree with you. Sometimes more is bad, less maybe
Yeah.
better.
Yes. No. That's
So
that's always a good thing to check your own. What are my motivations here? Am I treating myself or the patient?
exactly, absolutely, very good point.
Any other tips or pearls that you would offer for anyone who might be taking care of people with subarachnoid hemorrhages or aneurysms in general?
Well, I mean, it's interesting disease. There's a lot of research in this area. A lot. Hopefully, in the future, we'll have a lot more treatment options. There's a lot of treatment that I did as a resident that we're no longer doing. For instance, the magnesium drip, the statins. So a lot has changed in just a few years that I've been dealing with these patients. But I think the best thing we can do is to prevent rebleeding in these cases, and we know rebleeding carries a higher risk, is to recognize these cases. I mean, they can be easily missed for a migraine and missed for enteritis, the flu. And so I think the best thing we can do is think of it whenever we see patients with headaches, and if our suspicion is high, is to rule those out. And as far as other pearls, I think a lot of it relies on early diagnosis. Most of the other pearls, I think, are end up kind of more in the ICU realm, and because there's a lot of other complications with these patients other than neurological. There's pulmonary, there's cardiac.
Right.
So it's a very complex disease condition.
Actually, that's a great point. Would you mind talking about the subarachnoid heart? I know
Yeah.
that's a topic that I don't think I hear enough about. This might be a little selfish on my part, but
No, yeah,
hopefully our
good, good.
listeners
I
will
mean,
indulge us.
yeah, I think, I mean, in the ICU, we see it quite a bit, and it may be manifested with low blood pressure, and we think they're septic, but they're not septic. They just have a high troponin, EKG changes of ischemia, and unfortunately, this can look very similar to an MI. And the only way to rule or to diagnose this and exclude this is with an echocardiogram and some vessel imaging. And echocardiogram usually is very straightforward, has stress cardiomyopathy, where um, it has apical ballooning, for instance. The ejection fraction can be low, and the treatment is supportive. Now, if it's ischemic, the treatment is very different. And the etiology or the pathophysiology behind that is basically the subarachnoid hemorrhage, inflammation affecting the hypothalamus, a lot of catecholamine surge affecting the heart. And these cases can happen, also coincide with DCI as well. So a lot of things can be happening to these patients at the same time. And your choice of pressor that you use in these patients to raise the blood pressure, if it's low, also depends on the echocardiogram features, whether it's levofed or whether it's phenylephrine based on the echocardiogram features. But yeah, you can have stunned myocardium, Takotsubo's, or it could just be they had a poor heart and the stress caused them to have an MI. And so a lot of things. And then if it's stress cardiomyopathy and repeat the echocardiogram down the line, there you can see their ejection fraction starts to recover, the heart starts to recover. And if it doesn't, you're maybe a little worried and want to do some more ischemic workup.
Gotcha. So if there is that concern for like the rise in troponins and maybe some ischemic features on an EKG, do they normally get a heart cath while everything else is going on as well?
Yeah, I mean, if we're suspicion is less towards Takotsubo's and more towards ischemia, a heart cath is something they get, but not necessarily acutely, unless we think that they're having a STEMI. Just because of this dilemma of blood thinners and heparin while they're in the acute bleeding phase. Um, but yeah, so if they need it, they end up getting it, but perhaps not acutely unless it's a STEMI.
Gotcha. Yeah, no one wants to put a stent in and then not be able to put on antiplatelets or
Exactly.
heparin or something like that.
Exactly.
That's always a dicey proposition.
Absolutely.
Well, that was great. I appreciate you coming on and talking with me about all these issues that can come up with subarachnoids. If folks want to find you online, is there anywhere that they should be looking for you? Are you on Facebook, Twitter, anything like that?
Not necessarily. I use those platforms a lot, to be honest. But if they need to get a hold of me, uh, I'm on the University of Maryland website page, and my email is there. I'm happy to respond to anybody that has any questions.
Awesome. Thank you so much. I'll put a link to that in
Appreciate
the
it.
show notes. And thank you once again. I really appreciate it.
I really appreciate you having me, and thank you so much. Have a good weekend.
You too.
Take care.
Thank you everyone for listening. If you enjoyed this podcast, please rate, review, and share it on Apple, Spotify, or wherever you get your podcasts, and please subscribe for future episodes. You can reach me on Twitter at Dr. Kentris, that's DrKentris, or by email at theneurotransmitterspodcast@gmail.com with any questions or show suggestions. We'll see you all next time.